we're going to kick off. Are we good to go?
Well, just a second. He's on the phone.
Okay, great.
Disqualified.
Let's hold off.
I love my Cleveland team because of my past, but I love you guys.
Petros, you want to come on over?
Okay, here we go. We've started. We've kicked off. This is the final. Where is the cup? Where is the cup?
It's right in front of you.
Oh, here is the cup. Here is the cup, which is going to be won by the end of the day. We've got. We're gonna be about half an hour, no longer. There's going to be a winner by the end. We've got two teams. We've got team LA on our left here, and Tanya, do you want to introduce your team very quickly?
Monty Powell from City of Hope and Petros Skrivas from University of Washington.
And Shilpa, maybe round of applause, very reasonable. There's support, there's general support. Team Cleveland, you couldn't have guessed because you're in your Cleveland Browns. Brown's not my favourite colour, I have to say. But Farah, would you like to introduce your team very quickly?
Shilpa Gupta, Dave McDermott, Brian Rainey.
Okay, fabulous, fabulous. So I'm doing the marking this time, Tony, after the fiasco last time. Is that okay?
Am I doing it?
No, it's me, it's me. You're happy with that? Good, he's happy with that. Okay, so we're going to, as you know, it's buzzers. If you buzz in, you're going to have to answer the question. I'm going to stop talking, and if you get it wrong, it goes to the other team. The first question, which state in the United States of America has the most cancer deaths?
Sorry, can you repeat?
Oh, most cancer deaths. I'm going to say California.
California is the right answer.
Wow.
It has the highest
Team LA
population.
didn't get that one.
Yeah. They're in denial. They're in denial. That's why. They think they've cured them all. No, that's denial. That's a good question. Okay, so
It's a high population, right?
Yeah.
oh, here we go.
Yeah, we just.
So this study here is the double antibody drug DAD study, which looked at. Congratulations to the Boston team.
Who's on the side?
Sacituzumab govitecan and enfortumab vedotin. What did this study show, and what would you do next?
This study showed, this was an early phase study looking at safety and early efficacy, and it showed responses in majority of patients. The safety.
What was the response rate?
70%.
70% is absolutely right. Okay. And what was the design and what was the toxicity?
The toxicity was reflective of the enfortumab vedotin and sacituzumab with neuropathy, myelosuppression, diarrhea.
Yeah.
Neutropenia.
And the last question around this is, what would you do next with this doublet data?
We could think of designing frontline trials with doublet and IO.
So triplet trials.
A triplet and
Okay.
versus the doublet of EV-Pembro.
So-called Daddy-O trial.
The Daddy-O
Daddy-O.
trial.
Excellent.
And there are things to add there, if I'm allowed.
Far
but
away, Petros,
with
far away.
My sister allows. So 30 patients, 23 patients actually, 23 patients.
Small study.
Small study, small sample size. Very impressive response rate, as you said, 70%. There was a dose implication. The dose that was selected to go forward was 8 milligrams per kilogram for the SACI with growth factor support, and 1.25 milligrams per kilogram for EV, and that will be going forward. And I think it will be interesting to see the combination.
What was the main criticism of the trial?
Small sample size,
No.
not randomization.
No.
There was one treatment-related death.
There was, so there was a treatment-related death. I think I think the main criticism of the trial was there was a dose escalation after the first dose, where instead of reducing the dose, as many would do in a phase 1, they introduced GCSF, which is an unusual modification in the phase 1 trial. Not necessarily the wrong thing to do, but they dose escalated rather than dose reduced and introduced GCSF, and they did that because of the neutropenic sepsis.
So when you get the right answer, who gets the points?
By the way,
I possibly could win this cup.
I got on the time, right, with the sacituzumab.
Okay, we haven't finished yet. So sacituzumab govitecan, this is grade 3 or 4 toxicity. All of them, which has the most, going down to the least. Your team still, yes?
Yeah, neutropenia,
It's first, yes, correct.
diarrhea
Yes, correct.
are the main ones with this, and lethargy. And
Lethargy's
vomiting
third,
is the
and
least.
vomiting's last. It's absolutely right.
Very good. Wow.
What's the name of the pivotal randomized phase 3 for sacituzumab govitecan versus chemotherapy in pre-treated patients with advanced urothelial? Tropics 04 is the right answer again.
And is there an MVP award?
Which drug has caused this skin toxicity, and what are the extreme versions called?
This is enfortumab vedotin plus or minus pembrolizumab. Extreme versions are Stevens-Johnson's and TEN.
And what is the difference between Stevens-Johnson syndrome and TEN?
Stevens-Johnson syndrome and TEN. TEN, this looks like...
This isn't TEN, this is earlier than that. Yeah.
Right, okay. TEN is more like...
TEN is actually less than 30%.
Yes.
Stevens-Johnson less than 30%, but otherwise I think 90%.
Right,
I think this is a 5 versus 2. Is that fair? Okay, here we go.
We think it is.
Yeah, it's fine.
Glad for it.
Let's get the points right. We've got a second question here. This is a buzzer question. It is a buzzer question. So what is the impact factor of Annals of Oncology to the nearest 10?
60?
Well, it is 50, so that is within 10. So it's the correct answer.
All right, cool, okay.
It's actually 50.5.
It's going to become
Okay.
60 because of the new editor-in-chief.
Yes, there you
not
go.
It's trending there.
Right, so here we go. This is the Sunrise 1. This is unresponsive, high-risk, non-muscle invasive bladder cancer, receiving TAR-200, which is its pretzel device, and this releases gemcitabine. It's given in combination with sotrovimab in this trial. What's the results of this study? It was presented a randomized trial.
This trial was presented initially by Sia Dannesman at AUA, and the follow-up was Andrea Necchi at ESMO just a couple of weeks ago. Only cohort 2, which STAR-200, was presented. This is a pretzel administering intravesically gemcitabine. This is given once every 3 weeks to the patients. The trial we saw was only 30 patients, so small sample size. 23 out of 30, which represents 77% based on the blinded independent
I'm going
committee.
to stop you there
had
because
complete
there
response
was
rate.
2 of the arms were presented, not 1.
This was AUA. The ESMO was only 1.
Yes.
Yes, and the sotrovimab part was discontinued,
Yes.
and there's only TAR-200 going forward.
So the
And
TAR-200,
ESMO
so this is the data here that's presented with 72 versus 38%.
This was AUA.
Correct,
Sia
yes.
Dannesman.
Yes.
The follow-up with larger sample size,
Yes.
77%.
Yes.
With blinded committee, 80% with investigator-based response rate.
Yeah.
ESMO data. And Andrea Necchi.
Showing off.
Okay, and Petros, there is a Sunrise program of Sunrise 1, 2, 3, and 4. Could you describe in broad terms what those trials are based around and give as much detail on the Sunrise 1, 2, 3, and 4 program as you can?
Sunrise is BCG and responsive NMIBC. That's the design that you saw over there. TAR-200 is what we'll look forward for more data. And probably is the first one to result, to give more, to give data at a given endpoint. Sunrise 2 is still ongoing, accruing patients. It's a sotrovimab plus TAR-200 combination versus chemoradiation and bladder preservation, a randomized phase 2 trial. Sunrise 3 is BCG naive setting, looking at the TAR-200 plus sotrovimab in the BCG naive population versus BCG. And Sunrise 4, we're opening very soon, is neoadjuvant MIBC, cisplatin ineligible patients, sotrovimab plus TAR-200 versus, I think it was versus the TAR-200 alone in a version of treatment in cisplatin ineligible neoadjuvant MIBC patients.
Oh, go Petros.
Anything,
Nice.
I don't know, that doesn't sound right.
Wow.
anything from this team to add to the
MVP.
Sunrise program, including TAR-210?
The TAR-210 data is with the erdafitinib in the pretzel, and that was very early data presented at ESMO.
Lovely.
In NMIBC.
So we're going to go 5 versus 1, I think. Is that fair?
Yeah.
Okay, so we've got a question here. Which
this a
Greek...
buzzer?
Is it a buzzer question?
Yeah, this is a buzzer question. Which Greek iconic building has been replicated in Nashville?
Parthenon.
Oh, we buzzed first.
Who
We
buzzed
Who buzzed first?
We buzzed first.
LA buzz first.
Yeah, definitely.
And
Definitely.
Monty, you did, yeah, okay, so Monty, what is the answer?
100%.
Monty
Go
and
for
I
it.
went running around it. Actually, the
have to
three
give
of us.
Petros this one.
No, go ahead.
Parthenon. It's
Parthenon.
yeah,
Parthenon,
that's
of
absolutely
course.
right.
Is the correct
Yeah.
answer.
Which I got a picture from Brian last year.
Okay, fine. We'll just give
What did the Zircon clinical trial investigate? What's the name of the investigated agent? What does it target? What's the sensitivity and specificity? And how might this work as a therapeutic target?
Yeah. This is a good friend of ours from LA, so this is very appropriate, Brian Shuck, who presented this trial at ASCO GU. This looked at girentuximab, which targets CA9. The sensitivity and specificity of small renal masses, if I remember correctly, was around 85 and 90% respectively. And it might work as a therapeutic agent. There's actually some trials right now ongoing with radio labeling. With a theranostic.
So this is an overview of the drug. What do you think about the targets moving forward, and what do you think about the therapeutic options being successful in renal cancer? How exciting is this as a new target?
I certainly think that in this particular space, with the small renal mass, it's not something that we as medical oncologists, sort of typically see. I imagine this would be in Sia's domain and that of the urologist. But, if we do, really have some success initially in turning this into a, therapeutic compound, Memorial has a trial, I believe, that's ongoing looking at this phenomenon. I can easily see this moving into, late settings in renal cell carcinoma. And, we've had some nice discussions around maybe sort of using this as a means of, perhaps having an early assessment of active residual disease in renal cell, which sometimes is a problem as we look at imaging, conventional imaging.
Anything to add from this side?
No, I agree. I mean, G250 is a really old target, right? So the target's been around forever. It's just that there's now, a new antibody, and I agree, I think there's great therapeutic promise for this.
The 5-1, I think, is the answer to that. Are we fair with that? Yeah, it seems reasonable.
You can ask us. I mean,
Who sung the song, The Drugs Don't Work?
boy.
Which band? They just make, the drugs don't work?
The Verve.
The Verve is the right answer!
I can see the neurons firing over there.
It's a great
Okay,
band. Great
here we
band.
go.
It's good, right?
So we've had this discussion already in our earlier session, but we're going to have it again, and perhaps it might have a different slant on it. So what were the PFS and OS results? Was the control arm valid? How does this change crossover? And was crossover needed in this trial? And I'm going to let the other team come back and perhaps push back a bit on some of the answers if they don't agree. So Tanya, your team, do you want to take this on, those questions?
Yes, so this was a randomized trial of the lutetium PSMA 617 in MCRPC that's taxane naive. So it was a standard dose of the lutetium PSMA for up to 6 doses. The primary endpoint was rPFS and was strongly positive with a hazard ratio of 0.41 or 0.43, depending which data cut you look at. But the overall survival, which was not mature, fewer than 45% of the events reported, was 1.1 and broadly crossing the level of 1 for the 95% confidence intervals. The median rPFS was 12 months for the PSMA lutetium.
And so it comes back to those two questions about the control arm. And what's your take on the control arm of this study? Was it appropriate? Should it have included taxane therapy?
We would have learned a bit more if it were designed like Triton-3, where physician's choice could be a second AR pathway inhibitor or a taxane. So as we discussed this morning, this is a population that's really not ready for taxane or not maybe eligible for taxane and may not be completely representative of every MCRPC patient that's progressing on an AR pathway inhibitor. The control arm has been widely criticized, and yet it remains the control arm for multiple phase 3 trials. And I think it's not placebo. They're 20% or so response rate, showing that there is some activity, and so we just can't say how this compares to taxane, whether one should be sequenced before the other, but this shows that the treatment is active in the pre-taxane setting.
Why is there such a major disconnect between progression-free survival with a hazard ratio of 0.4 and an OS with a hazard ratio of 1.15?
So this study was not powered for survival. This is immature data, and they allowed crossover, and there was a very robust crossover, more than 80% of patients, and so it becomes very difficult to evaluate overall survival when both arms get the treatment.
If that's the case, does this not just show that it's better to give it later in the disease? if you have crossover, those patients get it later, and the outcome is at least as good, does it not just show that later therapy is better?
Well, so our PFS was strongly in favor of getting it instead of the second ARPI, and the overall survival data are inconclusive at this point.
Brian, do you want you moderated the session. Do you want to push back on any of what Tanya said?
I mean, I was called immature earlier, so
You were.
pushback. I think there is a huge disconnect here. Obviously, it's immature, et cetera, et cetera. We need to see the follow-up, but I think it's really interesting if it doesn't sort of drift back to one, right? Let's just hypothesize that it stays there and it's final. Then I think we have to sort of start to question sequencing and roles and why is there this disconnect. But we'll see.
But what was reassuring is when you look at the fatal deaths, the toxicity, we're not seeing some kind of alarming signal that this is costing patients their survival early on. So I think that if we had seen that, then I'd be much more worried about that OS of 1.1.
But we also don't have long-term toxicity data, what it does to their marrow or subsequent cancers.
And we have not seen that data, like MDS or leukemia, we have not seen such signals for the trial. So patients may want to get the best therapy first, and this was a low-risk population, so it's an appropriate therapy selection for this population.
Tanya, do we know the right number of cycles, and do we know the right measurement of the biomarker to maximize outcome for these patients?
I would say we absolutely do not know the right number of cycles. We don't know the right timing to give them. There's a lot of interest in the adaptive designs to maybe give a couple cycles if there's an outstanding response, wait until there's more PSMA active disease, and that may get more out of the number of doses over time and reduce the toxicity by allowing more recovery. We don't know what biomarker tells us what's the best response. A lot of us are using PSMA PET. There are not well-established criteria yet, but it does make sense that you want to see continued expression of the PSMA target if you're going to continue treating with the PSMA-targeted therapy.
We're going to go 5 and we're going to go 1, if we may. I think that's fair. So we've got the next question.
Up on scoring.
I keep the score here, 17 versus 8.
It's 17-8. Is it 17-8?
Petros.
Oh my
You
goodness.
should get a point off for that.
Yeah.
You're doing a great job scoring.
Which North African country has the highest incidence of urothelial cancer?
Egypt. Egypt, schistosomiasis.
Egypt
Squamous
is the
cell
right.
bladder cancer.
Egypt is the right answer.
I feel like there's an overrepresentation of bladder cancer.
Okay, bad news, I got it.
What is the PET News study? What's the primary endpoint of this, and what did it show?
This was actually a very important investigator-initiated trial by a good friend from Toronto, Dr. Kala Sridhar, in the University of Toronto Princess Margaret. Kala is great, did a great job presenting the data. I think the session you co-moderated, I think. So this is patients who were actually muscle-invasive disease, non-metastatic, may have been node positive, it's not negative, not positive. The main question was, does PET-CT, FDG PET-CT make a difference as a clinically useful imaging modality in MIBC in terms of decision making? The short answer, this was a negative study, so PET-CT did not affect the primary endpoint, so it was not useful. And you made the point, actually, Tom, that you should not use it. Kala, though, took a different approach and said maybe specific patients, borderline cases who may use it. The uptake of, I think, if I remember correctly, of chemotherapy was about 60% in both arms, not very different. So overall, limited role of PET, not standard, maybe selected patients may use it.
And what about the primary endpoint, the proportion of patients not receiving expected treatment? What do you think about that endpoint, and what conclusions can you draw from the role of PET in non-muscle invasive bladder cancer?
I think overall there was no significant difference in that endpoint. I think it's a meaningful endpoint for this study. I think the utility of CT with IV contrast or MRI with gadolinium is better imaging. I don't think PET is adding too much into that baseline. I think selected cases, maybe neuroendocrine bladder cancer, maybe some lymph node that may be borderline, may have some utility. But I think overall there was about the same proportion receiving treatment, again 60% or so in both arms got chemotherapy.
So here, I'm sorry, it's a big build. So here are some summaries. Overall, the survival made no difference with the PET arm. Disease-free survival was also very similar. There was a difference in PET-CT in that more patients didn't get the expected surgery. They ended up having radiotherapy and other modalities. I think the conclusion in the end is that the utility of PET in early urothelial cancer is perhaps less than we might thought, and many of us are using it. Certainly our institution, we've stopped using it based off this. I think it causes more confusion than solutions, in my opinion. I think we're next to a buzz around question, if we can.
All right.
So Walter White was a...
Score?
oh, sorry. I'm going to go for 4 and 1. Is that fair? 4 and
Sure,
1.
we didn't say anything, so we'll take a
You get a point. I think you get a point for that. Okay, we get a point for that. Okay, Walter White was a character from a program called Breaking Bad. What cancer did he have?
Lung cancer.
He did indeed have lung
Stage 3
cancer.
Watch a lot of TV. Oh no, prostate cancer.
So this is a summary of amides in M0 prostate cancer. And the question which I want to ask here is match the drug. So here are the 3 drugs. You've got enzalutamide, apalutamide, and darolutamide. I want you to match the drug with the adverse event profile. So you can see here, this is the adverse event profile. Which one is which?
So seizures, dizziness, falls enzalutamide.
So purple is which
And-
one?
Oh, purple, hold on.
I see 3 different columns.
So you've got 3 drugs here. You've got penzalutamide, apalutamide, and darolutamide.
Okay.
Each column's a different.
And each column, so you've
Okay,
got
yes.
purple. Which one is purple? Which one is dark?
Purple
Purple
is
is Enza.
enza.
Which one is light blue?
Light blue is, hold on, rash, apalutamide.
So
There's-
enza,
so-
apalutamide, and dark blue,
Is the darolutamide.
darolutamide. And Tanya, are you happy with that? Or Tanya, your team happy with that?
No, I think the purple is darolutamide. The rash is, so the second one is apalutamide, and then the third one is enzalutamide.
That's what we
That's what he
said.
said.
You said enza purple.
No, purple is the last, right?
That's dark blue.
I think we're having
I
color.
think the color
I'm
problem.
colorblind, so I can't
We
tell.
thought the last is purple. Come on. No, seriously, the last one is
Okay,
purple.
so let's make a
Next time we
clarification.
need a column A,
The
column B,
first column A,
B.
the first column, second column, third column. Fire away. First column.
Third column is enzalutamide.
Okay,
Yes.
well, then we
Second
agree.
column is
Yeah.
apalutamide. First column is darolutamide.
There we are. Congratulations. Fabulous.
Colors.
Yeah, purple. I mean, come on.
That looks purple to me.
That does to me too.
I think the score is
12 to 0.
5-0. 5-1, 5-1, 5-1, 6-1, 6-1, 6-1, 6-1. What's the
In
overall
case you
score
can't
so
tell.
far?
Okay.
There's no
Where
real-
are we on a scoring?
22.
15 to 22. So this is an important question. In minutes, how long does it take light to get from the sun to the planet Earth?
8 minutes.
That is the right answer.
Wow. That goes.
How do you know that?
Wow.
Why do you know that?
I have no idea.
Oh, and now it's the kidney cancer. but-
That was impressive. That was good. That was good. Wow.
Like,
So here we are.
can you see?
This is cosmic.
No.
This is the answers aren't written here.
I did not.
This is the Cosmic 313
I
trial.
promise, I promise.
What were the efficacy data? What were the toxicity data? Were there any problems with the study? And what happened? And what happened in the poorest subgroup?
No problems with the study. Monty.
Yeah, sure. So in terms of efficacy, the PFS hazard ratio is 0.73.
promise.
In terms of toxicity, what really sort of stood out, as you might imagine, triplet had more toxicity. It was AST, ALT rises that were probably most prominent, around 20 to 25%. Problems with this study are that, you sort of see that, it's one of these situations where maybe, the toxicity of the regimen got in the way of treatment, so fewer doses of IPI were rendered on the triplet arm, perhaps less cumulative dosing of cabo. And what happened in the poor risk group? This is sort of a paradoxical result. I think we all sort of thought that, the poorest group would actually fare best with this regimen, but hazard ratios actually seem to be a bit better in that intermediate risk population.
And let's move forward.
We'd like to add.
Oh, well, yeah.
We're desperate for points
Yes,
here.
okay, I understand. So what would you like to add? What would you like to add?
So that the response rate was marginally better in the triplet.
Yeah.
Right? The CR rate was low in both arms. I think it was 3%.
Yeah.
Tox data, I think 58% needed high-dose steroids, and I believe it was the same number who didn't get all 4 doses of IPI in the triplet arm. David, feel free to help out at any point here. Problems with the study is that we haven't seen the overall survival data.
That's actually.
But we know what it'll show. The overall survival will be dead negative.
Well, we know it's negative, yeah.
We don't know that. I mean, for the audience, we don't know that.
I just told
You
you.
know, we may predict. We don't,
Yeah.
and we've not seen a signal yet, so we have no idea what it might
There's
show.
no reason to expect that unless the patients on the ipi-nivo were excluded from ever getting VEGF, like the study was
David,
done.
you're
For
not
those of
helping
you
our
who are
point,
watching
Buzz.
this, we've just did a whole hour on this issue.
I understand. Right.
There's strong-
All right, but here's the
strong
point.
disagreement.
But here's the thing. If you looked at treatment-free survival,
Yes.
they would almost certainly favor ipi-nivo because there are going to be more patients alive off drug on the control arm. It's the
move
best
on. Let's move on.
ipi-nivo study ever.
We're going to move on if we
Really
can.
good point, David.
Negative point.
How many points do we get for that?
Negative point.
Negative points.
So here we talk about the progression-free survival. We're also talking about the poorest population, which is, shows that there are some subtle differences between those two, which may or may not be relevant in the future. We've got 2 more questions left. We're going to give this group, I mean, it was fabulous, Petros. It deserves 5 points, but I think it was a brilliant comeback,
Yeah.
and it also deserves 5 points.
Whoa.
All right.
There we are. Yeah.
Wow.
So we've got 2 questions. Who was Tesla, and what did he invent?
Magnetic fields.
Yeah.
Physicist, magnetic fields.
Physics, magnetic fields.
He invented magnetic
Oh,
fields.
discovered.
Well, that's not right then.
Discovery.
Pretty sure they existed before he.
Okay.
Okay, let's do it.
Here we are. So this is the second final question. So this is FGF-altered urothelial cancer and recent progression in the lungs. You folks need to come up with an answer, and then this team can challenge them. So previous chemotherapy for advanced disease.
So this is FGFR altered urothelial cancer progression. So you have previous platinum-based chemotherapy, I assume, right? You mean?
Yes, so previous platinum-based chemotherapy for advanced disease.
Fantastic. So the patient has visceral disease. I would like to go for a response in this setting. So we have chemo, we have ERDA. I will go for enfortumab in that patient. Oh, I will go for enfortumab in that case. You can make an argument for pembro-EV because the FDA label does not specify line of therapy. Having in the patient is immunotherapy naive, so you can go with pembro-EV or EV alone based on cancer burden, how much I want to control the disease, the response need. Then chemo, if you have chemo followed by avelumab, makes it even easier. We can go with EV alone because you already have avelumab IO therapy there. So we'll go with EV alone in the middle box, and then if you already have EV pembro for advanced disease, and then you go to dafitinib second line, I think you can go with chemotherapy, probably platinum-based chemotherapy third line, and reserve SATSI for later.
So previous
you look at the
chemotherapy
score.
for advanced disease, what have you got, Petros?
What's that?
What's the story? For previous treatment for advanced disease, what are you giving?
High cancer burden, want to control disease,
You only can pick one. You only pick one.
pembro EV.
You said enfortumab before.
So what is the treatment? Previous treatment, advanced disease. You've had Gemcis or Gemcarbo, and you've progressed. One treatment.
One treatment will be, in that case, will be pembro EV.
Pembro EV.
Yeah, this is
Okay, so that's previous chemotherapy. You've got advanced cancer, FGF alterations. You're giving EV Pembro.
you already got ERDA, right?
No.
No. Let's get. So it's first line chemotherapy.
Okay.
Significant minus points.
So you've got first line. You've got.
I thought you give
first,
ERDA before.
No. You've got an FGFR alteration. You're not.
Oh,
had
I see.
So you FGFR
Oh, I
alteration,
see.
and you get first line.
Wait a second.
First line
Wait a second.
chemotherapy.
How many answers does he get to
First
get?
line chemotherapy.
A lot of chances.
No, the patient
Just
had
like with
ERDA
the
before,
colors,
right?
we have
No
to understand
order.
the
No
question.
order.
Oh, okay.
First line
Okay.
chemotherapy.
Previous chemotherapy for advanced disease, I will go, in that patient, I will go erdafitinib. Chemotherapy avelumab will go erdafitinib again.
I'm going to pass it over to the other side. So previous chemotherapy, no immune therapy. We have held a Thor trial recently, which showed a pembrolizumab. And what's the answer to the question?
Pembrolizumab.
And why is that?
Because the Thor trial did not show that using erdafitinib first is better
Than
There's
pembrolizumab. That, I think, is the correct answer, Petros.
Why? You want the response 40%.
So here we go. No, so you're still in control. chemotherapy and avelumab for advanced disease. What's next, Petros?
You want a response in visual metastasis. You want the response.
Chemotherapy and avelumab for advanced disease, Petros.
Chemotherapy, avelumab, advanced disease is FGFR altered.
Yes.
You are between ERDA or EV.
Yes.
There's no right answer. It depends on comorbidities and toxicity profiles.
I buy that. Agreed.
Either way,
And the last one, EV pembro for advanced disease. What's next?
I think erdafitinib is a reasonable option there. There's no data randomized between ERDA versus chemotherapy. Depends on toxicity profile, but ERDA has level 1 evidence for the Thor cohort 1. So it's a reasonable option for IO exposed patients. So ERDA is reasonable in this population.
ERDA is reasonable, but it does not have the label for prior non-platinum treated patients.
In the Thor cohort 1, prior platinum chemotherapy was not mandated. It was given in most patients, but was not mandated.
I agree with you.
So I think we're going to give 4 points each.
Oh, okay.
4 points each. So this is the last
How are we
question.
doing?
The last question, I think, is a 7-point delta, if I'm right.
Okay, but
There is a
It's an
7-point
8-point
delta.
question.
So it's a 10-point question.
Oh.
It's a
okay,
10-point
all
question.
Is it a buzzer question?
It's a buzzer question, but it's not a do or die. It's not a do or die buzzer question.
Dave
It's
has
very close
something
to it.
say.
just to be clear, on the last thing, they got, the only reason they got answers even close to right is because you reread the
And that's
question
why
to
the
them.
last question's worth 10 points, David. Otherwise, it wouldn't.
Yeah, I think we're good.
Yeah, we're good, David. I mean, you were a long way behind. There's been a degree of catching up.
give you extra, we
I've
donate
done my
points,
best.
we donate
He knows how fast light travels.
We gotta get this guy's focus. We gotta get this, Petros. We gotta get this.
Okay, here we go. The Tiger study is a cancer trial. In which tumor type is it?
We buzz first for sure.
We
For sure,
Good.
for sure.
No, they buzz first.
buzz.
I think
LA,
that's just do
LA.
listen.
Wait.
No, that's biased.
We're asking Monty's fellows whether he buzzed in first. I don't get it.
They did buzz first. You buzz first.
Cleveland.
Tigers final, right?
Cleveland.
This testicular cancer,
Yes,
very important trial.
yes.
And of course, it's led by our good friend in Memorial Sloan Kettering,
Oh, that was the
Right?
second part.
Darren Feldman.
Darren Feldman.
We said that first.
But we buzz
It's between high-dose chemo stem cell transplant or standard dose chemo in the salvage setting.
That was also one of them.
But accrual was saved when Tom stepped in and brought an ERTC to boost accrual to Tiger, right? That
That
bonus
wasn't
points.
one of them. There is one more part. There's one more part you have to get.
What is the question?
I
You
can't
already
finish.
buzzed. You already buzzed. So he can't read anymore.
It finished accrual. And
That is the last part of the question.
It is?
We have a
Yes.
winner of the Uromigos.
Wow. Awesome. Wow. Tanya,